Dr. Abdullah, and we come to the last speaker, Dr. Karim. Dr. Karim is an associate professor of cardiology and intervention cardiology in Cairo University. It's called Qasr Al Aini or Cairo University. Dr. Karim is giving to us a case about angina management in clinical practice. Dr. Karim.
Thank you so much, Professor Sobhi, for the kind introduction. I'm Karim Mahmoud. I'm going to address the management of patient with chronic coronary syndrome in clinical practice. Actually, this is a 53-year-old male. He is a very smart patient and he's keen to know every detail about his disease. He has a risk factor. He has diabetes mellitus and hypertension. Both were controlled using oral medications. And he started to have typical or cardiac pain of 3 months duration before presentation. These pains occurred on exercise, and it was described as Canadian class 2 to 3. So he started to do the investigation in the form of ECG that was normal. The echocardiography also was normal with no regional wall motion abnormality, normal ejection fraction, and no valvular regurgitation. He was instructed to do exercise ECG, and exercise ECG was negative. However, as the patient continued to have a chest pain, so we think about other modality of investigation, which was CT. Actually, the exercise, he did the exercise ECG before presenting to us. So on doing the CT,
can I stop you, because this is a case? Can you make it interactive? It's better to be this. Yes, we have time with us.
Sure. Yes.
Julie, this is the patient of Karim coming to you. What you're going to do? They left Karim to you. And you have a calcium score high, exercise test negative, have angina. What to do now for the patient?
So of course, I mean, the guidelines tell you if you have a high calcium score, you should do a coronary angiogram. But if we didn't do the CT, if I saw this patient before the CT, the question always arises: do you want a functional assessment or do you want an anatomical assessment of the coronaries? And I tend to favor functional assessment more, because even if the CT did not show any obstructive disease, this patient still can have angina, and that you will get it from functional assessment. So if the CT, if the place that you do CT and they can do FFR, for example, then that can help you. But I generally tend to go for functional assessment, imaging modality, so stress MRI or a nuclear medicine or a vitamin echo or a stress echo if that's something that you have in your facility.
Abdullah.
But CT scan, then go for angio.
So you don't do angiogram, Abdullah. This is diabetic, young, typical angina, negative stress test, good LV function. Are you do cath for this patient, or you routinely go for CT or the vitamin echo?
Yeah, the CC, and it says high calcium score. What do you mean? Is it more than 500, more than 1,000?
1,000.
Are we able to see the calcium? I mean, I do CT. I know how to read the CT. It depends. If I can see that if left main is not included and not proximal, I will really try optimize my anti-anginal medication. I will not go prematurely. That's what I do.
But I think as you said in the guidelines, your slide regarding you have to do a CT in all the patient, excuse left main and the proximal AD, and that's why Karim did CT and high calcium score.
I will not do coronary angiography, I'm saying.
Okay, the Sharif Wagdi, are you do cath for this patient before CT or after CT? Sharif, do you hear me? We lost Sharif. Okay, go ahead, Karim.
So based on the high calcium score, and because we didn't get enough information about the coronary anatomy, we actually think about coronary angiography. However, the patient choose to continue medical treatment for a while and see if his symptom will be controlled with medical treatment. So this was the initial treatment of our patient. It's form of aspirin, clopidogrel, nebivolol, isosorbide mononitrate 50 mg, rosuvastatin 20 mg, and pantoprazole. This was his initial medication. And the follow-up, the patient continued to have chest pain despite this medication. So as it's an interactive case, what do you think is the next step for this patient?
What's missing now? What's missing? Dr. Jerry, what's missing? We have beta blocker, nitrates.
Yeah, I mean, you can add an anti-anginal, but I think you need to know the anatomy. I mean, as you said, initially you offered them coronary angiogram and they refused. And you have a high calcium score and you don't know in which arteries these high calcium scores are. So you need to do a coronary angiogram.
Is any correlation between the high calcium score and a number of vessels affected, or just determined that they have atherosclerosis and maybe only single lesion? Dr. Abdullah, you're a good reader.
Yeah,
for CT.
the calcium scoring, doctor, you're able to know where the calcium scoring is. Is it left main? Is it LAD? You're able to do that, from the calcium scoring itself.
Yeah.
And you can then say, okay, now I will go for CT coronary angio if we want to continue that one to see the lumen as well. So what I do actually before I jump, and you look at the patient anti-anginal, it's not optimal. Patient need anti-anginal here.
But this patient is diabetic, a very high risk patients. And they have typical angina. I think for me, I will do angiogram, try to sit with him and convince him with just coronary angiogram. Otherwise, if he refuses, if he's very old, he's young, he's 54, it's not 80. If 80, maybe I add a second, maybe. Karim, what you are going to do for your patient?
So based on, as he is still symptomatic, I advised him to do coronary angiography and he agreed this time. And this was his coronary angiography. This is, as we can appreciate, we have atherosclerotic vessels. The left main is okay. The left circumflex, we can appreciate that it had ectatic change in its proximal segment. Let me show that here. And also we have an atherosclerotic LAD. We have a diffusely diseased this second diagonal branch, and we have a lesion at the mid to distal LAD. And also we have this subtotal occlusion of the atherosclerotic right coronary artery. So I think the patient have a coronary anatomy that can explain his symptoms. And we revascularize the patient using 2-drug eluting stent in the right coronary artery and the LAD. So we kept the patient on the same medication after the coronary.
Why I continue on the nitrates?
Okay, because I continued nitrates actually for a while. I did that for some patients if they have a diffuse coronary artery disease, and I can, if they are symptom-free on the follow-up, I stop the nitrates after that.
Okay.
So I think about that. However, the patient on the same medication, the follow-up, he has a marked reduction, a 50% reduction of his symptoms of his angina. However, he still had chest pain, despite the revascularization and despite this medication.
But he became symptom-free for a while, then.
No symptom-free. On follow-up after 4 months, after 4 weeks, sorry, he still have the chest pain, but in a lower frequency and the lower severity than he had before revascularization.
Dr. Abdullah.
Yeah, but again, the coronary angiography you did, was it calcified that area? This is another maybe region which is not seen. That's why I'm saying calcification. Where were the calcification, and where was this lesion compared to the calcification? For me, doctor, what I do, I mean, I intervene. Maybe I do ballooning at the especially distal area. I might do DCB rather than putting a stent.
Yes.
Young man.
Dr. Jewelry, are you treating the diffuse disease with DCP or just making a medical treatment for this kind of patient? Because this is also an indication for the second angina, a second anti-anginal treatment, rather than, because if they're small vessels, it's difficult to put a DCP, but it's a bigger vessel. I think Abdullah is right to put a DCP. what you're doing in your cath lab?
So, I mean, I think he has a lot of disease other than the disease that was treated. So he requires actually more anti-anginal therapy. So I think adding an anti-anginal at this point is very crucial. And I think, yeah, given his profile, trimetazidine would be the next step.
So Karim, what you did?
So to conclude for all the audience, we have a coronary artery disease patient that was investigated first with different diagnostic modality, reaching to the coronary angiography that proved that he have a coronary artery disease, a diffuse coronary artery disease explaining his symptoms. And we did the revascularization for the most critical lesions on his coronary arteries, and putting him on anti-anginal treatment in the form of beta blocker and nitrate. However, the patient is still symptomatic despite his medication. So we are thinking what is missing. We did revascularization. We on beta blocker, nebivolol 10 milligram, a very good dose of beta blocker, and isorbide mononitrates 50 milligram. So we think about the cardiac cell and the metabolism as Professor Dr. Jouairia mentioned. And as we can appreciate, the most important step here is to add a drug that targeting the cardiac cell and the cardiac metabolism, which is the trimetazidine MR. If we look to myocardial ischemia results in a major disturbance of cardiac metabolism. Here we have a reduction of glucose oxidation in the cardiomyocyte, which is very important for the cardiac cell, and the increase in the fatty acid oxidation. And this will lead to a reduction on the ATP, and the reduction of ATP will lead to increase in the cell acidosis, increase in the calcium overload and lactate. All of these will lead to injury of the cardiomyocyte, will lead to increased angina and the cardiac dysfunction. So thinking about cutting this deleterious circuit by shifting the metabolism into the glucose oxidation and reduction of the fatty acid oxidation, this will provide the cardiomyocyte with more ATP and will lead to decrease the deleterious mediator, improving the pH of the cell, decreasing the calcium overload and decreasing lactate, and can help our cells to keep live and function. And this is the rule of trimetazidine MR. And as Professor Abdullah mentioned, we have the first-line drugs for managing the patient with chronic coronary syndrome, and we have the drugs that we add in addition if the patient is still symptomatic, to reduce the angina and improve the exercise tolerance. And the patient should be tolerable to this drug and should not have any contraindication to this drug. These drugs are nicorandil, ranolazine, ivabradine, and our drug that we decided to add, which is trimetazidine MR. If you remember, our patient has a controlled blood pressure. His blood pressure is about 110. Actually, also his heart rate is about 60. So adding the drugs that can reduce heart rate will be a problem, maybe a problem in this patient. So we choose a drug that won't affect the heart rate and the blood pressure, such as the trimetazidine MR would be beneficial to these patients. And in selected patients, such as maybe the patient with diffuse atherosclerosis, a class 2B, we can start combination from the start, the first line and the second line treatment. So,
can you leave this slide back, please? This is a very important slide for the whole series. The indication of using a second drug. It's 2AB, 2BC, 2BB. It's 2. It's number 3. It's like the diagram, the white diagram. It's low heart rate, low blood pressure. Number 2, which 2BC. Number 2BB, if first line treatment be considered the first line. And all the patient is 2AB, which be a second. It's upgraded from 2B to 2A. Am I right? Any comments about this, Dr. Jury, Dr. Abdullah, Dr. Sharif Wagdi? Because the audience should know that this is an important drug with a class 2A, B, or B. Nothing more, no comment.
Yes, no comment. It's clear. It's a clear message. Once
Okay.
you are still symptomatic, it's a class 2A to initiate the trimetazidine.
Okay, go ahead, Karim.
So back to our patients, actually with adding anti-anginal treatment with another mechanism acting on the cell metabolism, help these patients actually and improve the angina class. The patient also had a marked reduction of angina episode, even he was physically active and can regain his physical activity and he can walk and exercise again. And he was able to follow his daily activity as we mentioned. So this is very important for the patient to control his symptoms. It's very important to the patient with chronic coronary syndrome. If we look to the data, I will focus on the data that compare the trimetazidine MR with other anti-angina treatment, and starting with the protective or potential protective effect of trimetazidine MR on the cardiac cell. This was proven in this trial that showed in the patient undergoing PCI, trimetazidine MR helps to reduce the pre-procedural myocardial injury as evident by reduction of troponin I. And this is very good trial that showed that trimetazidine on the follow-up showed a reduction of the number of angina attacks per week. This happened despite a different combination: beta blocker, calcium channel blocker, beta blocker, long-acting nitrate, or the three together. So it works with the all drugs, either monotherapy or combination therapy, dual combination or triple combination. It shows a consistent benefit of using these drugs in the symptomatic patient. And actually also this is the old one that compared the trimetazidine MR with the nitrate in combination with beta blocker. So we have a baseline therapy with beta blocker and comparing if we add trimetazidine or nitrate. And actually trimetazidine MR showed a reduction of more reduction in the angina attack and more improvement in exercise capacity. So we have a drug that he is hemodynamically neutral. He does not affect the heart rate, doesn't affect the blood pressure, and help to improve the myocardial ischemia and exercise capacity. This is what Dr. Sobhi was asking about, is the precaution of using the drug. If we look to the trimetazidine MR, it's a drug with a very good tolerance and safety profile. Actually, I think most of us agree that the trimetazidine MR is one of the safest and the neutral drugs, and our patient can tolerate it very well. But it has some precaution, especially in the patient with movement disorders. It's contraindicated in the patient with Parkinson's disease and the tremor and movement disorders, as well as in the patient with severe renal impairment. And there is no drug-to-drug interaction reported to this drug. Actually, we have other drugs such as ranolazine that is contraindicated in the patient with prolonged QT interval, as Professor Sobhi said. Nicorandil is contraindicated in combination with other phosphodiesterase 5 inhibitors, such like the nitrates, in the patient with cardiogenic shock and heart failure and low blood pressure. Actually, also the nitrate is contraindicated in the patient with HOCM aortic stenosis and with the use of the phosphodiesterase 5 inhibitor. So to conclude, in some patients, we need to metabolic and hemodynamic approaches. I believe this can be done right from the diagnosis, because the hemodynamics, it will act. Also, the metabolic approach will act in this patient and will help this patient to reduce their symptoms and improve their exercise capacity. We have the drugs that act at the cardiac cell, providing more ATP for better cardiac efficiency, and it's proved to be powerful and with a reduction of anginal symptoms and improvement of the exercise capacity. Also, it has a excellent safety profile and minimum side effect with no reported drug-to-drug interaction. And thank you so much.
Thank you, Karim, very much for this wonderful case. The interaction, I think it's Dr. Sharif, we asked, can you ask your audience about this case, because we lost you for a few minutes. This is the case of diabetes, young with angina, negative stress tests. Are you going to justify to do a CT or angiogram or medical treatment? How can you proceed for these kind of patients?
Actually, if he's having a normal echocardiogram and normal ECG, I would like to go, as Dr. Abdullah said, for non-invasive imaging will be my first choice before proceeding to invasive coronary angiography based on his normal ECG and normal echocardiography. So I would go first for non-invasive before going to invasive coronary angiography. Actually, I have
yeah, go ahead.
I have a question for the whole panel. We show the picture of the coronary angiography having an ectatic LCX and most probably with a slow flow. What is the role of adding rivaroxaban for this patient with the low dose of 2.5 milligram twice per day as a line for treatment for his anginal symptoms and improvement outcome?
Dr. Julie.
So I'm not aware if there is studies for that, but this has been the clinical practice in our center at least. When we have patients with ectatic vessels, we feel like, I mean, there are studies for rivaroxaban and chronic stable angina, and it makes sense that this pathophysiologically will work. And actually, the patients that I have that have started on rivaroxaban low dose did not come back with angina. So it seems like it works with ectatic vessels.
Abdullah.
Yeah, I agree with Dr. Juwaria.
You know, actually, there's no single study for this, but I know that French people does with Germain Telescope and also together with Bernard Chevalier, they are doing a registry regarding rivaroxaban. You know, we in the past we're using warfarin, then doing P2Y12 with aspirin, then coming with NOAC. So assume that maybe rivaroxaban adding to aspirin or adding to P2Y12 may be effective for such kind of patients, but we are not sure of it in this on the guideline. Karim, do you have any idea about this use?
Yes, if we look to Compass trial studied this issue, but it was a dual therapy with aspirin and rivaroxaban 2.5 milligram. This was for the patient with diffuse vascular affection, diffuse vascular bed affection, especially if they have peripheral arterial disease. And it was associated with a good outcome. However, this was an expense of increased bleeding. So it might be used, but not in a triple combination. Here we have a patient that received 2 stents, so he should receive aspirin and the Plavix. Maybe on the long-term outcome, we can extend his treatment with aspirin and rivaroxaban 2.5 milligram twice, based on the good result of Compass trial. But we should exclude the high bleeding risk or high bleeding risk patient from this.
But the question, Sharif, is not a diffuse disease. Is about ectatic vessels. I mean, diffuse disease with a polyvascular is a Compass patient.
Yes.
With rivaroxaban, maybe I saw a single 2.5 twice, maybe after 1 year for a long time. But if you have diffuse disease, if you have ectatic, actually we don't have. You cannot put in a single trial. It's only registers.
There's no trial, but as I said, I have some patients, young patients, ectatic vessels. They keep coming back with angina, and you know that the problem is, once we started, we thought about, you know, it makes sense because, as you said, we used to do warfarin before. So once we did rivaroxaban low dose, actually they didn't come back with angina. They just follow up, no chest pain. So I think maybe this is something to look forward to in the coming registries.
You remember the first question of mine to you, Sharif. How do you know that this patient will need a hemodynamic drugs or a cardiometabolic drug or both? But Dr. Karim case is a patient classic. If he did 2 stents for the LAD and right coronary, but still symptomatic, this could be this patient indirectly still have a need cardiometabolic drug. I mean, maybe microvascular angina or maybe increased IMR. So this can be a trial and error, but we don't have evidence to know how to make it except to IMR. Karim, do you have any methods rather than non-invasive to see that still this patient cardiometabolic? I mean, this patient may need a nuclear study to see this still have more than 10% ischemia, so he needs a cardiometabolic, or just to trial and error?
This is good question, Professor Sobhi. I believe the patients that have a high ischemic load are the patient who have a significant epicardial coronary artery stenosis. The patient with microvascular angina might have an ischemic myocardium on the nuclear imaging. However, the area of affection would not be so great. I think it's mild to moderate at maximum affection of myocardial ischemia. So based on that the patient have no symptoms and is compliant to his medication, I want to prescribe for him another investigation for his myocardial ischemia.
I have a question to all of you now. When do you use two anti-ischemic drug apart from nitrates? I mean, ranolazine and trimetadine, ivabradine and trimetadine, trimetadine recurrendil. Do you have evidence of using these two drugs? Sharif, do you know the answer?
I usually combine maximum two for the long-acting nitrates and one of the second anti-anginal.
No response. What to do?
No response. For sure, there is something. I think this patient indicated for coronary angiography if still is symptomatic. I will proceed for. It's not logic to use more than two anti-anginal and one long-acting nitrate besides the beta blocker, and this patient is still symptomatic. This usually having a significant obstruction in his coronary, so I proceed for invasive coronary angiography or non-invasive coronary imaging to exclude any significant obstruction.
Dr. Jewelry.
I mean, there's no evidence for combination, but sometimes you're stuck, you need to do something. So generally, I do use trimetazidine. I can combine it with nitrates, beta blockers. I have tried combination with ranolazine, but for some reason, it never works. So every time I start ranolazine, the patient does not feel well, and I have to stop it with lots of different complaints that are not part of the side effects. So it's very strange. I don't understand why. Yeah, but so trimetazidine with beta blockers with nitrates works very well. And then you're stuck with some patients that you cannot.
Abdallah, forget about nicardine. I don't know, they don't have it. Ranolazine and trimetadine, or trimetadine and ivabradine.
I use them all, but I'm speaking about my patients. I spend time with my patients, tell them about how complex it is sometimes with refractory angina. I do the coronary angiography, and there are small arteries I will not touch. I mean, sometimes I use DCBs to help with opening that artery, epicardial, hemodynamic at least. Cellular level, I have to try this medication to get the benefit. But at the end of the day, they have to understand the limitation of this medication I have. It needs a lot of effort, doctor. Many things together.
Karim, what is the maximum for your patient allowed for him to live a normal life with your drugs? I mean, for the quality of life, is it depending on what in his age or on his effort before, on what he's satisfied? How can you estimate that? I mean, Sharif said that about SQ scoring, but how can you make it in your real life?
I think age is a number. Maybe we have a 70, 80 patients that is physically active and needs to perform his daily activity in a piece. So I will add a medication and will increase or titrate the medication to achieve a good exercise tolerance as much as we can, and as much as there is no contraindication or side effects happen to the patient.
Okay, Sharif, do you have any questions from your doctors with you? And I think I saw a lot of doctors. Ask them.
Any questions? Yes. Yes, Dr. Sub.
Thank you. About nitrates, now it is aggressive. Enough to give PMZ or even cardiac. Nitrates now regressing, and also invasive. Our strengths now also you should do if it is mandatory. We can give only in medical and so follow up. About اللي هو cellular, it is very nice and It's very nice. And if we give from the start that limit treatment, all the limits with TMZ, if there is a severe affection, blood pressure not reaches the 7, you can pass this, will not everything. Thank you.
Sharif, I can't hear well.
It's actually a comment further than a question that
Okay,
is
okay.
agreeing that the use of trimethazidine from the start is better than
Oh.
to use the long-acting nitrate due to the side effects and interactions
Okay.
with the nitrate. Any other
Okay, I think
question?
would you have any question? Any more
Yes,
question?
yes.
Okay.
Thank you. As this patient was diabetic, is the group of SGLT2 inhibitor can add benefit to reduce number of episodes of angina?
No, it's not related to the number of episodes. SGL2 is another story. Dr. Jerry, can you answer this question?
It's going to prevent heart failure in this patient.
Yes.
So of course, any diabetic patients should be on an SGLT2 inhibitor, regardless of whether they have coronary artery disease or not, regardless if they have heart failure or not. So that's a very important observation from you. And yes, this medication needs to be there for this patient.
So it's class 1A as a prevention. It's not related to the angina. It's, you know, it's if the patient has heart failure or left ventricular decompensation, if this patient has a preserved ejection fraction, heart failure, preserved ejection fraction, we have still EMPA only. Until we have the liver maybe in August, but this is for the preserved ejection fraction, heart failure. But if there is no heart failure, it's prevention of heart failure, but it's not related to the coronary anatomy or the number of angina. Okay, Abdullah, you need any comment about this use of other drugs rather than?
Yeah, I mean, if we should, although we are focusing today on anti-anginal medication, but we should not forget the medication which is evidence-based for diabetes, hypertension, all that.
Yeah, thanks. Yeah. My question to all of you is about the nori flow or the slow flow, which can be assumed to be trimethazidine has a few trials regarding this. Are you using this in this patient following PCI and this patient developed nori flow and then recovered, and then you give them after the PCI of this patient, using them such drug, trimethazidine, or not? You don't have data.
I mean, it's not a common practice. So not every patient with reflow ends up going home with trimethazidine. But I think if they still have symptoms of angina, then that's added. Usually it's in the first visit after discharge, not in hospital. This is actually our practice in my center.
Karim, do you have any?
I want to add some other, maybe it's beneficial in the NoriFlow. However, this is the theoretical knowledge. It can improve some data about the improvement of hemoglobin A1C and diabetes state based on increasing the glucose oxidation. So this may be the beneficial effect on reducing the NoriFlow effect.
I don't know why, because also ranolazine had the same. It's one trial for ranolazine showing that it decreased hemoglobin A1C. I don't know how. It's claimed, but the same like trimethazidine, it's decreasing hemoglobin A1C. Abdullah, do you have any evidence in your reading regarding this hemoglobin A1C and these two cardiometabolic drugs?
I'd rather to do exercise and diet rather than taking this for A1C.
Dr. Shafai, we have another question, please. A final question.
Post-corona, there is effect on the coronaries because it affects the epithelium. Corona. Have any knowledge about these signs?
Oh, yes. Corona or COVID has three parts in either developing infarction with a normal coronaries, or Takotsubo in the myocardium, or sometimes is a stimulation of the plaque rupture in already diseased vessels. This could be a speculation, only observation. And Abdullah, can you add anything?
COVID and what?
Coronary artery disease.
COVID is we will learn a lot, affecting everything, doctor, at the epithelial, endothelial, everywhere. So could be. I don't know. I'm just waiting.
Okay. Any
So,
information?
I mean, as you said, it affects endothelial function. It's a prothrombotic as well. So we have seen lots of coronary artery thrombosis without atherosclerosis. We have seen LV thrombosis. It is a pro-inflammatory process, and there is a huge cytokine storm with a severe infection, and we have seen cardiomyopathies associated with that. Now the debate is this actually the virus, or this is just the inflammatory process that happens because of the virus? This has been going on and off over the past 2-3 years now. And I don't think we're going to reach to a consensus regarding this. But we learn to deal with it. And as COVID-19 is disappearing right now, I think it's becoming less and less worrisome to us, I think.
Karim, maybe if we, any more information about the COVID and the coronary arteries?
The same thrombosis make a stable plaque unstable or myocarditis. This is, I think, the all we've seen the last year regarding COVID and the coronary arteries.
Okay, I think we come to the end. Dr. Sharif, if you need any more
No, thank
questions,
you. No,
we have only few minutes. I think we come to the end. I'd like to thank Dr. Jerry, the President of the Emirates Society of Cardiology. I think you'll be in the European next, maybe within a few years.
Maybe.
Because they like females. They like females. And I'd like to thank also Professor Abdullah Shihab, the Vice President of Emirates Society, Professor Sharif Wagdi Ayad, the board member of the CVRAP, and Karim Mahmoud, the Associate Professor of Cardiology, Qasr Aini. I'd like to thank the Emirates Society, the CVRAP, and the Servier for allowing us to have 90 minutes. I think I learned a lot from you, good discussion. We learned now with the wave 1, what is angina, how we make it hemodynamics, cardiometabolic, the frequency of anginal pains. We're not treating only the anatomy, we're treating the patient with the quality of life. So we have in our pockets now a second drug, which is class 2A, 2B, whatever it is used. As Abdullah said, I don't like to have two. It's already in your pocket. It is indication in 3. Remember this, the second line. Number 2 in selected patients, the first line, and in low heart rate and low blood pressure, together with the nitrates, so the beta blockers and the calcium channel blocker and chronic stable angina. And finally, we have a personalized approach. We have patient-tailored treatment, fast relief of pain within 4 weeks, and with the optimum medical treatment. I'd like to thank you, and كل سنة طيبين برمضان، وإن شاء الله برضه الإخوة المسيحيين أتقوا صايمين هنعيد عليهم بعد كده إن شاء الله. Thank you very much and see you later.
Thank you so much.
Take care. Assalamu.